All right, good morning. Today we'll have a very quick discussion on the headaches, and this discussion is most likely going to be from a PCP or a primary care physician's perspective, not from an specialist perspective, but how to have a very good approach when it comes to dealing with the patient who comes with the headache. Uh, so let's go ahead. I have the comments section turned on. If you have any questions in between, just let me know, and we'll continue with the tidbits or the stat pulse for the headache. Yeah, most of you know that the majority of the headaches that we have or that we're dealing with are the primary headaches. And with primary headaches, I say it could be tension headaches, it could be cluster headaches, it could be migraines, it could be a lot other more when it comes to the primary headaches. But around 70% or 60 to 70% of the headaches that we see in our clinics are the tension headaches, and then comes the migraines, and very rarely you see cluster headaches. And it depends on the geographical area. Some areas have higher incidence of cluster headaches. uh, Apart from that, when it comes to the primary headaches, it is not really important to just on spot diagnose the primary headaches and start the medication. But what is really important at this point of time when a person comes to you with the headache is that you need to rule out if there is not anything dangerous ongoing in the patient's brain. You need to rule out if there is a red flag out there. So it is very important that you as a PCP need to ask your patient if they have any red flags. What do I mean by red flags? Red flags, I would say, the worst headache of my life, or I would say my headache gets worse when I do an excessive physical activity, or when I'm having sex, or when I'm coughing, it gets really, really bad. Or maybe you say, what could be the red flag? Papilla edema, that is an increasing ICP, increasing intracranial pressure. That could be one of the red flags that you would see. So you need to rule out, you need to check out if there are any red flags or not. The question comes, what if the patient has got the red flags? So nothing to do. If you see there is a red flag, just refer them or direct them to the imaging. That is the first thing you would do. And with the imaging, we might ask what to do, CT or MRI. What is the option here? So the best thing here is, it is a very good line that I take from the American Headache Association, AHA, and it says that for all the cases, when you need to do an imaging, go for MRI, except for the emergency cases. When you just in an emergency, you need to rule out a stroke, you need to rule out a bleed, or anything like that, you could go for a CT. But for all the other cases, MRI is the best diagnostic modality when it comes to the headaches, and to rule out any other things. So that needs to be taken into consideration. Now, at the same time, I would also say that you need to keep some secondary causes of headache in your mind as well. I know you're done with the imaging, and it's all clear, all is good, and the patient could have primary headache, and you have ruled out all the problematic things. But at the same time, you also need to rule out some secondary causes that you can rule out with the help of the history, or with just a direct communication with the patient. What could be the secondary causes? It could be a morning headache because of obstructive sleep apnea. It could be a headache because of your sinusitis. That's mainly the frontal sinusitis. It could be a post concussion syndrome. It could be a trauma that occurred like 10 years ago, 5 years ago, 2 years ago, 3 weeks ago, and you're having the post effects of that trauma now. So need to rule out the secondary causes of the headache as well at this point of time when you are dealing with a patient with headache. Now you have ruled out all the things, right? You're done with the imaging, you're done with the ruling out the secondary causes. What to do now? Now you know, of course, it's not the tension headache. The patient doesn't meet the criteria for the cluster headache, and you, with the signs and symptoms, you think, okay, it's migraine. Fine, I need to deal with the migraine now. So what to do now? How to deal with migraine? What is the plan ahead to deal with the migraine? So of course, it depends when what kind of migraine it is, with the severity. It could be mild to moderate, it could be moderate to severe, or it could be a very severe migraine, depending on the frequency, depending on the intensity of the pain the patient goes through. So just uh, just see and just check what kind of migraine it is. So if it's a mild to moderate migraine, I suggest and I recommend that you start with the NSAIDs. uh, my favorite at this point would be naproxen. Why? Because it's first, it's long acting, and secondly, you don't need to take it too often. Like, you just take one dose, it works for 12 hours, then take the other dose. One bad thing that we normally do is, in migraines, we also take acetaminophen, as considering it as analgesic, which is not wrong. But the research has shown that acetaminophen does not have any good role or an effective role in aborting the acute episode of migraine. So just be mindful when it comes to the acute migraine, or when you need to have an abortive therapy for migraine. Just do not think of acetaminophen. In fact, go for ibuprofen, go for naproxen. My favorite, naproxen. Go for it. It's very good when it comes to controlling the acute attack. Well, if it's severe, and or maybe this doesn't work, the NSAIDs did not work, naproxen didn't work, ibuprofen didn't work, what to do now? So you have a good option of triptans with you. uh, it's a it's a good class of drugs, but just be cautious when you have a patient with an uncontrolled hypertension, or have a history of ischemic heart disease, or a history of stroke, because um, triptans have vasoconstrictive properties, and it's not a very good option when you have to deal with the patients of vascular diseases or stuff like that. So it's better to avoid triptans and just do not give it to them. But triptans, when it comes to triptans, the meta-analysis told us that, two triptans, in fact there are three, which are most effective. You have zolmitriptan, you have sumatriptan, but it's not very effective. It is effective, but out of all the triptans, I am going to tell you which triptans are the best options that you can use. So you can use alotriptan, you can use almatriptan. Um, these are the better ones. I don't remember the name of the third triptan, but which is also a very good triptan when it comes to the conclusions from the meta-analysis. But these triptans are very good. Almotriptan, allotriptan. So if you have these in your pharmacy, just go for it. They would work immediately. They would work effectively. So for abortive therapy for severe cases, or the NSAIDs did not work, you go for the triptans, but be aware of these things that you don't need to give triptan in, like uncontrolled hypertension, vascular diseases, blah blah blah. Now, one question which normally pops in our mind is how to start a triptan, like what dose, or what should be the frequency, or whatever. So these are the questions that don't normally come up. I say that start with half the full dose, like whatever the triptan you are choosing, and the maximum dose for the triptan. I would say start with the half full dose. Like if the maximum dose for a triptan is 100 milligrams, I would say if you're starting a triptan for the first time in a patient, start with 50 milligrams. A lot of neurologists, a lot of clinicians, they start with the maximum dose. But then what do you do when the maximum dose doesn't work, or when you have a relapse, or when you have another episode of uh, migraine very soon, what do you do then? So nothing to worry about. You can just change the drug. You can just change the triptan. If you used sumatriptan for the first time and it's not working, there is no harm in changing or switching to the other triptan. Start almatriptan, start with alotriptan or zolmitriptan. You can always switch with the triptans, and in most of the cases, this worked. At least in my experience, this literally worked when it comes to switching the classes of the triptans, because not all triptans work in every patient. Uh, and you have a variety of triptans, honestly, like 7 triptans. I don't even remember the names of all the triptans, but you have 7 or 8 different kind of triptans that you can use in your patients or play around. So yeah, now the patient, the person whom you started triptans, or who came to you for the first time with the migraine, or initially diagnosed as migraine, but your medications are not working. The patient is having recurrent episodes of migraine again and again, 2 episodes a week, 5 to 7 episodes a month. Triptan is not working. You did everything. What to do now? Of course, if your patient is requiring a lot of medications for abortive therapy, like 2 3 episodes a week, so this means he's taking 2 to 3 triptans a week, right? Which is not okay. I mean, it is not fine to take more than 3 triptans in a week, or it is not okay to have um, an ibuprofen or naproxen daily just because you have a persistent headache. This gives us an indication that this is a high time you start prophylaxis. It is time to start the prophylaxis in the patient, and you actually have a lot of good options when it comes to prophylaxis. Um, it's good to start with the prophylaxis. In my case, when I see the patients or of migraine, and there are more than 4 episodes a month, I directly start the prophylaxis. I put them on prophylaxis regime without giving a second thought. So you have a number to choose from when it comes to prophylaxis options, but the established efficacy for prophylaxis options you have is with the anti-seizure medications. You have topiramate, you have divalproate, you have beta blockers. The best ones to choose for the prophylaxis would be metoprolol and propanolol. Go for it, and they would work. Just start with the prophylaxis, daily prophylaxis, whatever it is, whatever your respective specific guidelines tell you how to deal with the prophylaxis. But you should know that now it's the time to start prophylaxis and go for it. Now you started the prophylaxis. What defines your success? What does it mean if your prophylaxis worked, or your treatment worked, and you are a successful neurologist or a PCP? What do you do now? How do you know that? Of course, you know that if the frequency of the migraine is reduced to 50%, let's say if a person used to have 4 migraines in a month, now he's having or she's having 2 episodes, or 1 episode a month. It means you are having a successful regime or a treatment plan for the person. Now, I had a patient, and I gave him all the options, and like the entire plan was given to him, and told him about the prophylaxis, about the abortive therapies, but she was not very happy to start with the medications, like despite of the counseling, despite of the sessions I had with her, and such a bad pain she had to go through all the time, but she was not happy with starting the medications. So what do we do in that case scenario? How do we deal with that? This is also a common question that a lot of GPs ask neurologists, like what to do in that scenario. Well, in that scenario, you have some non-pharmacological options to deal with the migraine. Cognitive behavioral therapy. I'm sure a lot of you have heard about it. So we do CBTs for migraine. We also do progressive muscle relaxation therapy, which is basically there are alternating periods of tension and relaxation, uh, and this works for the patient. So go for it. You have a lot of Now we have a lot of mobile apps, and you can easily find out, like, it's just a click away. Just Google it and how to do the progressive muscle relaxation therapies, or there are some CBT apps. You can look for it. More than that, what is really important, like, this is an established recommendation, like a proven trial, a proven research that I'm going to tell you now, that aerobic exercises and a proper sleep, a regular sleep, a good sleep habit also prevents you from getting migraine attacks, and it serves like a prophylaxis. And one of the trials of which conclusion I tell you is that um, 3 times a week, if you do 40 minutes of cycling or 40 minutes of let's say walk 3 times a week, it is equal to giving a prophylaxis with topiramate or a beta blocker. So that's wonderful. That's I think all for today. These are the basic things that I was supposed to tell you about headache. For the questions, yeah, we can. I end the video here, but we can entertain the questions separately. Thank you so much. That's all from my side. See you soon with another topic.